intensified National Iron Plus initiative was started, and it was named Anemia Mukt Bharat by our PM. Anemia Mukt Bharat has 6 strategy wherein the beneficiaries are grouped under 6 categories, 6 interventions are there, and 6 institutional mechanisms are there. Of the beneficiaries, we are concerned with the pregnant population. Around 30 million pregnant women are being covered under this one of the 6 beneficiary groups. These are the 6 beneficiaries. Now the 6 interventions, the key interventions are prophylactic iron and folic acid supplementation, periodic deworming of women and other beneficiary groups, intensified round the year changes which lead to solid body and smart mind campaign, and digitalization of the testing and again treating at the point like testing care site, then fortification of foods and dealing with other problems which lead to anemia like malaria, hemoglobinopathies and other things. These are the 6 institutional mechanisms which are more on the administrative purpose. We'll again come back to this. So when we see as a whole the causes of anemia in pregnancy, or in general for that matter, they start with biomedical, which are a part of socio-epidemiological, which are a part of politico-developmental. Here, as we can see, the basic nutritional deficiencies, worm infestations, everything, they are in general a bigger problem when a country as whole is not as progressed enough as other developed countries. That is where we see 3 levels of deficiencies which are because of which lead to anemia. Now this is an important slide wherein we have to know that not all anemias in pregnancies are because of iron deficiency anemia. The only thing which we are generally taught is to start with iron supplementation. We need to keep in mind there are other anemias where we have to either refer or undertake further investigations. Now another important thing is, by the time an iron deficiency anemia is diagnosed as reduced hemoglobin levels, the body is completely exhausted of iron stores. We can see from the normal to iron deficiency anemia, there has already been an iron depletion, an entirely reduced stores of iron. So whenever we are treating, we need to address that and replenish the body stores. This is the cycle where it goes on with various ages. The anemia just doesn't end. Now we all know the signs and symptoms, all the basic symptoms and all the basic signs, which I will skip through. Now what Anemia Mukt Bharat has in specific related to pregnancy anemia is we have to establish delayed cord clamping, and initially till recently there were 100 mg tablets which were being provided from the government, where it has been reduced to 60 mg elemental iron, but those are sugar coated tablets which will reduce gastritis. Then again focus on women in reproductive age group. Now this is the cutoff, WHO cutoff of anemia in pregnancy, wherein hemoglobin less than 11 is considered anemia, mild is 10 to 10.9, moderate is 7 to 9.9, and severe is less than 7. Very severe according to ICMR is less than 4, which we are not taking into consideration here. For anybody who gets pregnant, irrespective of whether they are already anemic or not, you start off with the pregnancy prophylaxis. That is, after the 4th month, you give 180 days of 60 mg iron, which also has 500 microgram of folic acid. Now, there are certain practical aspects wherein we need to tell that iron kind of causes gastric irritation. So we need to give it after a meal, preferably during night times, preferably along with lime juice or any other things, and avoid taking it with meals and even for that matter coffee and tea. Alright. Also, calcium reduces the iron absorption. Calcium is one of the other things which is given in general to the pregnant women, so we need to take them on different times. Test and treat intervention for anemia from the field level, wherever it is possible. Initially, less than below the block level health centers, we use a digital hemoglobinometer. Otherwise, we use a semi-auto analyzer. Based on the hemoglobin levels, we treat them. This is before referral. So wherever we test, we treat them, we talk. That is, we help them with the dietary control and other things. If the hemoglobin is between 10 to 10.9, that is, it is only mild anemia, we start off with twice daily iron now. Like the same tablet, it should be given twice daily. This has to be followed up after 2 months, wherein we again repeat for hemoglobin estimation. If there has not been an increase of more than 1 gram per deciliter, we need to refer it. We need to refer it to a further sentence for further investigations. Since we have based on only the HP, a complete blood count, if necessary any other say thalassemia or anything which has to be ruled out based on the ethnicity and other things, we need to do that. So start off twice daily, and uh, after compliant treatment, check after 2 months. If the HP still doesn't improve by 1 gram per deciliter, you refer it to higher center. Now, between 7 to 9.9, in this case, if she is far from term, that is, she is not going into labor anytime soon, we still have enough time. So we start off with again twice daily iron, but this time, right after 1 month, we monitor, we check for the hemoglobin increase. If it has not increased, we will again refer it and investigate further and see if she needs any transfusions and other things. Now, anything less than 7 is considered severe, irrespective of the gestational age, whether she is going into labor anytime soon. Kindly refer her to tertiary centers where they can conduct a detailed evaluation of all the anemia related investigations, look for the cause, and also transfuse, because that is something which could precipitate failure in the pregnant lady at any time. Now, those were the oral iron therapies. When do you have to start parenteral iron? That is when you find that despite compliance, the HP has not improved, or there is no compliance at all. Now, how do we look for compliance? We will ask for the color of stools the patient has been passing once she has been started on iron. If it is black colored stools, if she actually complains of some kind of gastric irritation, that means that she has been compliant and is taking the tablets, but there has not been any improvement. Here is when we go ahead with parenteral iron therapy. All right, it improves the iron content of the pregnant lady faster than the oral iron. Now, how do we calculate the dose required for iron supplementation in parenteral route? It is 2.4 gram, 2.4 into body weight of the pregnant lady, which is pre-pregnancy weight, into the difference between the target hemoglobin and actual hemoglobin. Along with that, we add 1000 mg for replenishing the body stores. Now, there are two kinds of preparations: iron sucrose and iron ferricarboxymaltose. Sucrose we give 200 mg in 100 ml NS over 15 minutes. That can be given on alternate days for a maximum of 3 times a week. And iron ferricarboxymaltose, in a week you can give up to maximum of 1000 mg. Ferricarboxymaltose is little expensive compared to sucrose. There are certain contraindications before you start on parenteral iron therapy. You need to look for any kind of hypersensitivities which already the patient knows, any liver disorders, acute cardiac failure, and more importantly, any thalassemias. Now, as I already said, there are certain anemias which look like microcytic microcomic anemias which are caused because of iron deficiency, but there are other things like thalassemia minor traits and other things which are not diagnosed on a grassroots level. So in those cases of thalassemia, iron overload should not be done and parenteral iron therapy is contraindicated. Now coming to specific complications of iron deficiency in pregnancy, it is like the whole machine is not working well. So she doesn't have enough weight gain, she goes into preterm labor, she has more chances of developing preeclampsia, eclampsia and other things. She's prone to recurrent infections, she's more prone to have placenta previa, she's more prone to again have